Hello and welcome to our new topic. Today we will review one of the most important drug groups in the management of chronic autoimmune joint disease, called disease-modifying anti-rheumatic drugs or DMARDs. Unlike NSAIDs or steroids, which only suppress symptoms, DMARDs modify the underlying disease process and prevent long-term joint destruction. Understanding their mechanisms, categories, and toxicities is essential for treating rheumatoid arthritis safely and effectively. Let's start. The learning objectives are shown. Please take a look. Rheumatoid arthritis is a chronic, systemic autoimmune disorder of unknown cause. It primarily targets synovial membranes in small joints but also produces significant extra-articular manifestations. The disease course is characterized by periods of remission and flare. Without disease-modifying therapy, joint destruction, disability, and systemic complications can progress rapidly. The modern strategy for rheumatoid arthritis is known as treat to target. This means defining a clinical target, usually remission or low disease activity, then continually adjusting therapy until the target is achieved. Regular monitoring is essential. Patient education, lifestyle changes, physical therapy, and gentle exercise all play supportive roles. For advanced disease, surgical options may be required. Rheumatoid arthritis management begins with conventional synthetic DMARDs, especially methotrexate. If disease control remains inadequate, biologic DMARDs, such as anti-TNF therapies or abatacept, are added. Targeted synthetic DMARDs, mainly JAK inhibitors, are reserved for specific situations, especially after failure of first-line therapies. While NSAIDs help with pain and stiffness, they do not slow disease progression. Corticosteroids help with flare control but are not suitable as long-term monotherapy. Conventional synthetic DMARDs remain the backbone of rheumatoid arthritis management. These include the antifolate methotrexate, the dual-component drug sulfasalazine, hydroxychloroquine, and immunosuppressants like leflunomide and cyclosporin. Cytotoxic agents like azathioprine and cyclophosphamide are used in special circumstances, mainly for severe systemic manifestations. Gold compounds, once common, are now largely obsolete due to toxicity. In addition to non-specific, conventional synthetic DMARDs, there are drugs with better defined targets and uses. Biologic DMARDs include monoclonal antibodies against TNF-alpha, IL-6 receptors, co-stimulation pathways, and B-cell surface markers. Biosimilars are increasingly available for agents like adalimumab and infliximab. Targeted synthetic DMARDs act intracellularly, mainly by inhibiting JAK pathways, offering oral alternatives to biologics. Methotrexate is an antifolate used at low, immunomodulatory doses in rheumatoid arthritis. At these doses, it does not act via classical anti-cancer folate antagonism. Instead, it inhibits the amino-imidazoline carboxamide ribonucleotide transformylase pathway, causing accumulation of AMP, which is converted extracellularly into adenosine, a powerful endogenous anti-inflammatory mediator. This adenosine release is central to methotrexate's effectiveness in rheumatoid arthritis. Methotrexate is the first-choice DMARD due to its strong efficacy and relatively favorable long-term profile. Side effects at immunomodulating doses are fewer but can include GI upset and elevated liver enzymes. Folate deficiency may lead to mucositis and myelosuppression, which can be mitigated by leucovorin given 24 hours after dosing. Rare toxicities include pneumonitis, pulmonary fibrosis, and cirrhosis. It is strongly teratogenic. NSAIDs may reduce renal excretion, thus increasing toxicity risk. Sulfasalazine is an alternative first-line DMARD, especially in patients who cannot tolerate methotrexate. It is poorly absorbed orally and is cleaved by colonic bacteria into sulfapyridine and 5-aminosalicylate. Sulfapyridine is the active immunomodulatory component. Sulfasalazine suppresses T and B cell responses. Common adverse effects include GI upset, headache, and rash, while rare toxicities include hemolysis and bone marrow suppression. Importantly, it is considered safe in pregnancy. Hydroxychloroquine is a mild DMARD used mostly in early or less aggressive disease. It inhibits lymphocyte activation, lysosomal enzyme release, cytokine induction, and phospholipase A2 activity. However, its therapeutic effect is modest, and its toxicity profile, particularly retinal damage, neuropsychiatric effects, myopathy, and QT prolongation, requires monitoring every 3 to 6 months. It is safe in pregnancy but should be used cautiously in epilepsy, G6PD deficiency, and psoriasis. Leflunomide inhibits dihydroorotate dehydrogenase, a key enzyme in pyrimidine synthesis. This suppresses T cell proliferation and B cell response. It is as effective as methotrexate and is often used as monotherapy or in combination. Adverse effects include diarrhea, elevated liver enzymes, alopecia, rash, hypertension, and weight gain. Leflunomide is contraindicated in pregnancy and requires careful monitoring. Cyclosporin acts by binding to cyclophilin and inhibiting the calcineurin pathway, thereby blocking T cell activation and cytokine transcription. Although effective, it has substantial toxicities: nephrotoxicity, hepatotoxicity, neurotoxicity, diarrhea, blood dyscrasias, cardiotoxicity, infertility, and increased infection risk. It can interact with NSAIDs and methotrexate, increasing toxicity. Because of these risks, cyclosporin is reserved for refractory cases. Azathioprine is a prodrug that forms 6-thioguanine, which suppresses purine synthesis and thus lymphocyte proliferation. Its activity depends on TPMT enzyme function. Toxicities include GI upset, alopecia, rash, bone marrow suppression, and increased risk of infections and lymphomas. It is teratogenic and used primarily for severe systemic manifestations or when other DMARDs are unsuitable. Gold salts such as auranofin and erythiomalate were historically used in rheumatoid arthritis but are now largely obsolete due to toxicity. Their mechanism is unclear but includes suppression of T cell activity and macrophage function. They distribute widely in tissues and are renally excreted. Gold therapy produces numerous adverse effects, often delayed in onset. Oral preparations cause GI upset and dermatological reactions including exfoliative dermatitis and chrysiasis, a golden discoloration of the skin. Parenteral forms may cause proteinuria, hepatitis, blood dyscrasias, neuropathy, or even lung fibrosis. Severe reactions require discontinuation and may need antihistamines, corticosteroids, or dimercaprol treatment. These risks have eliminated gold from routine rheumatoid arthritis therapy. Biologic and targeted synthetic DMARDs transformed rheumatoid arthritis management by directly modulating specific immune pathways. These drugs inhibit cytokines, cytokine receptors, T cell co-stimulation, B cell function, or intracellular JAK pathways. They are highly effective but expensive and carry unique risks, particularly infections. Biologic drug names provide useful clues about their type. Monoclonal antibodies end in mab, such as infliximab and rituximab. Fusion proteins end in sept, like abatacept. Targeted synthetic small molecules typically end into nib, as seen with tofacitinib and baricitinib. Recognizing these suffixes helps quickly categorize therapy options. Biologic agents include TNF-alpha inhibitors like infliximab, etanercept, adalimumab, certolizumab, and golimumab. IL-6 receptor inhibitors such as tocilizumab and sarilumab are used when TNF blockers fail. Abatacept inhibits T-cell co-stimulation, while rituximab targets CD20 on B cells. These agents are selected based on disease severity, comorbidities, and prior treatment response. Targeted synthetic DMARDs, particularly the JAK inhibitors, baricitinib, filgotinib, tofacitinib, and upadacitinib, block intracellular kinase pathways essential for cytokine signaling. They are orally administered, making them attractive alternatives to injectables. However, safety concerns include infection, thrombosis, lipid changes, and cardiovascular events, as tabulated in the next slide, so careful monitoring is required. This slide compares various characteristics of these agents. Take some time to carefully review them all. In summary, disease-modifying anti-rheumatic drug therapy is central to rheumatoid arthritis management. Treatment must be individualized, monitored, and adjusted to achieve remission or low disease activity. Conventional synthetic DMARDs remain foundational. Biologics add precision by blocking targeted immune pathways, and JAK inhibitors offer oral targeted inhibition. The choice of therapy depends on severity, response, comorbidities, and patient preferences. This slide shows the same concept in a different detail. The diagram shows how rheumatoid arthritis involves a network of interacting immune cells, including T lymphocytes, B lymphocytes, dendritic cells, macrophages, and fibroblasts, whose cytokines, TNF, IL-6, IL-17, drive inflammation and bone destruction. Biologic DMARDs precisely target key nodes in this network, interrupting the inflammatory cascade. Reviewing the latest EULAR recommendations is also valuable for understanding current best practices. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!